I want to start by saying good afternoon and thank you for allowing me to present at this conference. The Yakima Valley Farmworkers Clinic, my organization, is a large community health center with clinics in the northwest part of the United States, providing medical, dental, behavioral health, and other social services to low-income patients. A few years back, we began to take a close look at both the results of the care we were delivering and the changing financial environment we were in. From there, we designed a demonstration project that we felt could best serve our patients and prepare us for future reimbursement changes. We published our project in the December 2020 special edition of the Journal of Public Health Dentistry on value-based care and oral health. And this presentation today describes our transformation journey. So as everybody knows, dental caries remains the most chronic disease in the world. Multiple countries have tried various formulas of private and public sector care delivery to address dental caries with little overall success. Even in the world's richest countries, caries remains a critical health issue, particularly in the low-income populations. So I think a good place to start this talk is discussing why we felt we needed to transform care. And I'll center on two areas. One is population oral health, and the other is the changing financial environment. So in the United States, most dental care is delivered in private practice, with about 2/3 of our citizens covered by private dental insurance. The majority of low-income children's dental needs, however, are covered by public insurance called Medicaid. There is some adult Medicaid coverage, but that varies greatly from state to state. The Yakima Valley is a major agricultural center in the state of Washington. It's noted for its wineries, hops, fields, apples, pears, and other crops. But as a result, it attracts a large number of agricultural workers, primarily from minority, underserved populations. In the early 1990s, I was invited to join a statewide group concerning children's oral health. This group was composed of educators from the University of Washington School of Dentistry, our state's Medicaid program, and other leading advocates for children's oral health around the state. At that time, the statewide access for dental care for Medicaid children was about 27%. Our main thought at the time was that if we could improve access, we could improve overall health. And our report was generated from that group, and many initiatives were started, and we had a lot of success. And fortunately, our state has an oral health survey that they do every 5 years. So I've been able to track that progress, and particularly the progress in my home county of Yakima. So when you look at the slide, we had a lot of success. We went from overall, in my county, we were at 22% when we first started out for access to Medicaid children. And we ended up at, in 2015, we got up to 65%, and we topped out at 68%. We drove the untreated caries down from 27% to 8%. This is all really good news. The problem is that the caries experience not only did not decrease, but it actually rose, and our rampant decay doubled. What became very clear was that while access is absolutely critical for the individual patient health, it doesn't always necessarily affect the population health levels. At least that's what we had expected. Certainly, one of the reasons behind this is dentistry's surgical approach to oral health. Even when we access care, and even when the patient gets into the dental chair, what we do is we diagnose the disease, we fix the results, but we fail any serious attempts to prevent the disease. And this disease obviously is clearly preventable. This approach is both ineffective and it's very expensive. Even in countries as wealthy as the United States, there just is not enough money to drill and fill our way out of this problem. And it is a very expensive problem. Just to treat the 0 to 5-year-old Medicaid population in Yakima County is over $8 million for annually, and which is about a little under 7 million euros. The average annual cost for the state of Washington is a little over 74 million. And when you look at the $8 million, this is one small cohort of patients in one small county, in one state, in one country in the world. And if you multiply that out, obviously you get tremendous amounts of money that could be spent. And this doesn't even include all the costs, because there's other costs, including general anesthesia, hospital anesthesiology costs that it doesn't cover. So we've done everything right, and you know, we still had problems. We try to figure out, okay, what went wrong? Well, the first one is certainly the surgical approach. We are treating symptoms and not the disease. We're like our dentists, and they feel this too. They're like hamsters in a stationary wheel. We're running as fast as we can, trying to fill the holes, but the holes keep developing faster than we can fill them. And there's also limited access, because even though 68% access is phenomenal, still 32% of our Medicaid children did not see a dentist once. And my guess is those 32% are mostly high-risk children. And there's really not patient-centered care. We do risk assessments, but we don't really do real risk follow-up. And I'll talk about that in a minute. There's no case management. Dental disease, as far as I understand, is the only chronic disease with no case management. It would be crazy to treat diabetes that way. No motivational interviewing. Motivational interviewing and techniques like that are absolutely critical to stop the disease at the home level, to develop the habits they need at home to stop the disease. And there's only partial medical and dental integration, and we're working on all these right now. So why propose something different? Well, the data is clear. You know, we're helping thousands of individual patients, but we're doing nothing to stop the disease. And so this, we're doomed for this scenario to go on forever. There's new technology now that's available. We now have integrated health records, and we can unite with medical, and those medical records also come with reports that we never had before. We're able to now track high-risk children, and if we do our job, get them into the clinic or deliver prevention outside the clinic. And there's new techniques that we've never had before. While silver diamine fluoride has been common around the world, it is relatively new to the United States, sad to say. And there's now teledentistry, and I'll talk about that in a little bit too, on how that can improve access. And also state and federal funding definitely is changing in the United States. We're, particularly in the Medicaid population, they're going more to a value-based reimbursement, where we see the trend that more and more of our reimbursement is going to go from being reimbursed by the procedures we do to being reimbursed by the health outcomes that we can produce. These are my two favorite quotes. One is from Edwards Deming. Every system is perfectly designed to get the results it gets. So we're in the system because the system is designed to produce the carries that it does. And from Einstein, we cannot solve our problems with the same thinking we used when we created them. To me, both those indicate that the system for oral health delivery needs some major disruptions. So the first disruption I want to talk about is risk-based managed care. Our current dental payment system has failed low-income populations around the world because it pays for the procedure. It doesn't prioritize prevention. As long as we continue the same payment system we're under right now, we're always going to be doomed to get the same results that we're getting, and our patients are going to continue to suffer. To explain managed care, very simply, in the United States at least, managed care, instead of the government paying clinics and dentists directly to provide care to Medicaid patients, they pay a managed care company who then pays the dentist. The managed care company is responsible for a specific number of patients and are given a specific quality measures that they have to meet in order to get their money. Managed care, at least by that definition, in all honesty, doesn't change much for me or my patients. As I mentioned, instead of getting paid by the state, I get paid by the managed care company, and they throw in some value-based metrics. Again, that doesn't change much because there's very little skin in the game at the ground level. And that's where financial risk is the real true game changer. Risk-based managed care is very different from regular managed care. Risk-based managed care dental contracts are extremely rare in the United States right now. My organization actually sought out a managed care company, and we looked for a managed care company that was interested in developing a slightly different model. And we did find one, and it's a small project right now. We're looking at expanding it, but it's working financially, which was our first move, and then we want to see with all the other measures that we're putting in if it works for our patients. But as I said, it is a game changer because the managed care company and the clinic and the dentist become true partners. There's shared upside and there's shared downside risk. The best way to describe that is if the state gives our group, the managed care company and us, $10 million to treat X number of patients, and they tell us the parameters that they're going to measure us by, if we can deliver that care with a cost of $9 million, if we're really efficient, and it costs us $9 million, we share an upside or profit of $1 million. If that same care cost us $11 million, then we share a downside risk or a loss of $1 million. So because the managed care company and us are in the same predicament, it creates a lot of incentives to do things that we never had an incentive to do before, sad to say. What shifts risk in a favorable direction? Well, one is increasing specialty care. So we're hiring specialists into our program. We brought in orthodontists, an oral surgeon, pediatric dentists. And we're also, even more important, trained general dentists to increase their skill set. So fewer children have to go to a specialist. We're trying at least to reduce the number of patients going to an emergency room, because hospital emergency care for dentistry is the most expensive in the world. And it's also the least effective, because all they do is give antibiotics and pain medication. So we've developed a pilot project that we're testing out now to help divert patients from hospital rooms or hospital emergency rooms into the dental clinic, where we know we can provide both better care and cheaper care. We have to decrease the disease levels, and I'll talk about that next slide. And we also have to increase access by going outside the walls of the clinic. And the nice thing for us is these measures, we can do these now. They'll work even better in a risk-based managed care system, but it gives us time to hone our skills and figure out what works and what doesn't work before all this is, we feel is forced on us. The next disruptor is a clinical disruptor. And that is, we have to front load prevention. We have to use evidence-based dentistry. And as everybody knows, dentistry is full of non-evidence-based dentistry. And so we have to look at what is really working, and we have to switch from the preventative model to the surgical model. We're always going to need the surgical model. We're always going to need to pick up the drill. We'll never get rid of that. But the more we can reduce that, the better we are, the better our patients are, and the better we are financially. We have to use the electronic dental record better. And these are things that we are all trying to do. We want to, we're working on recalling by risk, in individualizing silver diamine fluoride and fluoride varnish schedules, increasing the use of glass ionomers for interim treatment restorations. We're utilizing new metrics to drive providers. And I have a slide on this in just a little bit, and this is absolutely critical. Things like carries at recall and different measures to drive procedures that dentists aren't used to doing, and procedures that they need to do. And also, probably the most important is utilizing techniques like motivational interviewing. We have to change the habits of our patients at home if we're ever going to get a handle on this disease. And the last disruptor is an access disruptor, and that is breaking down the walls of the clinic. We have to go where our patients are and not always expect them to come into the clinic. We're currently piloting dental hygienists embedded in the primary care team. And right now they're assessing the mouth, they're applying preventative procedures like silver diamine fluoride and fluoride varnish. They're doing motivational interviewing and also referring those that truly need the surgical care into our dental clinics. The next step is we're preparing for is to do this by teledentistry, where instead of assessing, they're actually doing dental exams with the help of a dentist in the clinic. The next step after that is to send those hygienists out into communities and expanding access through teledentistry. The idea is that the hygienists will have patient panels. There will be panels of patients that will either when they access, that will either be healthy, or they can, they have small disease that they can keep them healthy. And their goal for those children, healthy children, will be to keep them out of the dental clinic and only go into the dental clinic when absolutely necessary, and then send the kids that truly need the care, surgical care, into the dental clinic. So in the 1880s, the famous Irish mathematician, William Thomas, who was the first Lord Kelvin, said, if you cannot measure it, you cannot improve it. And our health center has adopted that as a mantra. We've determined that our success must be centered around measurement. And we not only want to prove our concepts, but we want to prove them in no uncertain terms so we can develop a model that can be replicated. And if it doesn't work, we'll figure something else out. Because all we know is right now is we have to change if we're going to improve our patients' lives. To do that, we're developing an operational and quality dashboard with the financial help from Delta Dental Washington Foundation. We're using the dashboard metrics. Basically, we establish baselines and then we establish targets. From those targets, we'll look at the dentists in the clinics that are most successful in achieving those targets, and then look at the workflows that they develop to get those successes, and then spread those workflows throughout the rest of our system. This process has worked really well for our medical program, who's very used to medical managed care, and we expect it to work the same in our dental program. And these are just some examples of our dashboard the way it currently is. The last one is something is a metric we're working on right now, and that is that we want to know the percentage of our patients with ADA caries classifications 1 and 2, because we know that's very similar to the International Caries Detection Assessment System. But we know 1 and 2 in the classification 1 and 2, we can prevent the disease. We don't have to pick up the drill for those. And so we want to know what dentists are doing the right thing and doing the preventative measures, and which ones are picking up the drill. And from there, we'll incentivize the dentists that aren't doing the right thing to do the right thing. And that's, we've tested that process out in different areas, and it's worked pretty well. So just a few more slides. What benefits are we seeking for our patients? We want to increase access by expanding outside the walls of the clinic. We want fewer invasive and anxiety-producing procedures, and we want to increase the chance of changing home oral health habits. For our dentists, we want the highest quality and evidence-based care, and we want them to know that they're actually solving a problem. Right now, it's really discouraging because all they see is disease coming in. And for our organization, we want to be competitive and ready for new payment models. And this is just the last slide. Where do we go from here? Basically, we want to measuring what we want to improve, which is reducing the population caries burden. And we'll do that by the dashboard that we're setting up. We want to try to find out, what works, evidence, putting in evidence-based interventions, expanding the dentist hygienist model into the community, and most important, measuring the impact of what we try. We want to make sure that we're shifting our clinics so from concentrating on just procedures to actually better health outcomes, and then it's redesign, repeat, redesign, repeat, and just keep doing that till we figure out what actually works. And I know this was a very quick summary of a complex transformation process we're in right now, but you have my contact information, and if if you have questions now, I'll be happy to answer. But if you have them later on, please feel free to contact me. And thank you for allowing me to present today.